My name's Dominic Power. I'm a consultant hand and peripheral nerve surgeon and one of the editors for OrthOracle Hand, Wrist and Peripheral Nerve. This short talk is about nerve transfer surgery and in particular about motor nerve transfer. Nerve transfer surgery is a technique used by peripheral nerve surgeons to restore function to key, important denervated muscles. It involves sacrificing an expendable nerve branch, known as a motor nerve transfer, or a fascicle from within a mixed motor and sensory nerve, known as a highly selective fascicle transfer, and these are sectioned distally and mobilized proximally. The recipient is the nerve branch to a paralyzed important muscle, and this motor nerve branch is sacrificed proximally and rotated distally, such that a tension-free coaptation can be performed using microsurgical suture techniques between the donor nerve and the recipient nerve very close to the motor point. And this is the point where the recipient or target nerve enters the muscle. The result is very rapid reinnervation and restoration of function. What happens, depending on the length of reinnervation and the duration of denervation, is the first symptoms that the patient experiences are tenderness within the muscle from small fibre regeneration. After this, the earliest twitches are seen, and these can be recruited and popularised by recruiting the donor muscle. Once power is restored to that muscle, neural plasticity allows independent function of the donor and recipient. For each individual popularised nerve transfer, there are follow-up periods during which expectation of recovery should be made. Typically, for an elbow flexor, early signs of recovery using the Oberland technique can be within 3 months, useful power within 6 to 9 months, and independent function within about 18 months. So where do I use nerve transfer surgery? Nerve transfer surgery was popularised after brachial plexus avulsion injuries, and these aren't really anatomically reconstructible lesions. So there's distal important muscle paralysis. And in a situation such as C5-6 brachial plexus injuries with intact C7, 8 and T1, key extraplexal nerves such as the spinal accessory nerve can be rerouted into the suprascapular nerve, and intraplexal nerves such as the triceps branches C7 can be used to reinnervate the axillary nerve. An Oberland procedure can be used to take a fascicle from the ulnar nerve into the biceps. Nerve transfer allows rapid restoration of function. Because it's so reliable, I've started to use it in other indications. So for instance, if a patient presents so late that reconstruction of a nerve gap is unlikely to give useful distal motor function, I consider using nerve transfer for key functional recovery. If a patient's had primary nerve surgery that's failed, nerve transfer can sometimes salvage the situation. In a patient who has such a proximal lesion that distal functional recovery is unlikely, or the surgical bed is so poor, then occasionally nerve transfer added into the reconstructive algorithm can improve the chances of a meaningful outcome for the patient. So in summary, nerve transfer is an excellent tool in the reconstructive toolbox for peripheral nerve surgeons, using sacrificable or expendable donor nerve branches or fascicles in the vicinity of the motor point of a more important non-functioning muscle, and simply transferring this fascicle and microsurgical anastomosis into the denervated nerve branch to the target muscle can allow prompt, reliable and rapid restoration of function.